our first EDI focused seminar of the quarter. We hope to have one every quarter, really. And I think Yates will tell us more about this. But today, as I said, our speaker is Dr. Yates Coley, who is an assistant investigator in the biostats unit at Kaiser Permanente. She's actually our former graduate student from our department. And before joining Kaiser Permanente, she was a postdoc in the biostatistics department at Johns Hopkins. Just as a reminder, you can ask questions anytime, either by putting them in the chat or by raising your hand. And that's really everything on my end. So yeah, yes, the floor is all yours.
Great, thanks. We're gonna retry sharing the screen here. All right, can you all see my screen?
Looks good, yeah.
Great. Thank you all so much for joining today. Just for a bit of context, the objective of the Equity, Diversity, and Inclusion in Research Committee sponsored seminar series is going to be to illustrate how statisticians can incorporate equity, diversity, and inclusion and anti-racism into their research methods and products. Like Lee already said, we are hoping to do this once a quarter from here on out. With that motivation in mind, I'm going to give a bit more of an applied talk that includes practical tips for how our research team did this, and welcome any questions about our approach during the discussion. So I'd like to start with a land acknowledgement. We are on the unceded ancestral lands of the Duwamish and Coast Salish people. We honor with gratitude the people past, present, and future of the Duwamish, Coast Salish, and other tribes who have stewarded this land for generations. I also acknowledge that clinical research like what I'm presenting today has been used to justify and to perpetuate colonialization of Indigenous people and their traditional land. And I share this acknowledgement as a means to reflect on the work that is needed to transform our research into a tool to dismantle colonial legacies. I'd also like to give a quick heads up before this presentation. My talk's going to include discussions of racism and race and ethnicity-based discrimination, and also about suicide. So these are challenging and emotionally draining topics, especially for people whose lives are directly impacted. And we are all living through challenging and emotionally draining times. So I wanted to take a moment to prepare you all for that content, acknowledge that it might be upsetting, and encourage all of you to do what you need to do to take care of yourselves. I'm also aware that my perspective as a white person is quite limited when discussing race and ethnicity, which is not in any way to excuse any missteps on my part, but rather to invite feedback when I make a mistake. As we are all aware, prediction algorithms have become ubiquitous in most aspects of life. They are used to select which ads we see online, whose posts appear first in our social media feeds, and which credit card payments are flagged as possibly fraudulent. Some uses of prediction algorithms have raised concern about discrimination and fairness. One prominent example is that of a prediction model to identify individuals prone to recidivism after incarceration. These predictions are used in courtrooms across the country to guide sentencing and parole decisions. An investigation by ProPublica found that Black people were much more likely than white people to be labeled as high risk for reoffending, and that these predictions were wrong. The false positive rate for Black people labeled high risk was nearly twice as large as the false positive rate for whites. So the impact of using this prediction algorithm was to keep more Black people in prison for longer, reinforcing the racist system of mass incarceration. So as we've seen growing enthusiasm for the use of prediction modeling with big healthcare data to improve care delivery, we've also seen concern about fairness and equity in clinical prediction tools. And this fear isn't unfounded. We're all aware of persistent health disparities across racial, ethnic, and socioeconomic lines, among others, due to systemic barriers to accessing quality healthcare. And we've learned from other domains using prediction algorithms, like the criminal punishment system, that there's a very real possibility that those disparities may be exacerbated rather than ameliorated if particular attention isn't paid to removing bias and ensuring equity. A recent prominent example was published in the journal Science in October of 2019. Obermeyer and colleagues showed that a commercial prediction algorithm that is commonly used by health systems to identify patients with more complex healthcare needs underestimated the needs of Black patients compared to white patients. So real quick question, Iardi or Sandra, can you all see my cursor on this screen if I use it to point out things on the graph?
Yes.
Yeah.
Great, thank you. So this graph shows that at each percentile of the algorithm's risk score here along the x-axis, the average number of chronic conditions that Black people with that risk score have, shown here in purple, is higher than the number of chronic conditions for white people, shown in orange. So the vertical lines on the graph here show the thresholds used to refer patients for care management services. And then we can see here from this difference, this vertical difference here, that Black patients had to be sicker, had to have more chronic conditions than white patients to be offered these services. So the impact of using this prediction algorithm is that health systems are disproportionately channeling beneficial services to white patients instead of to Black patients, further exacerbating racial inequities in healthcare access, treatment, and outcomes. So the crucial flaw in this algorithm and how it is used is that the algorithm actually predicts the amount of money spent on a patient's healthcare, not their actual needs. And since institutionalized racism affects every aspect of our lives, including healthcare, less money is spent on caring for Black people than is actually needed to meet their healthcare needs. So using healthcare costs as a proxy for needs underestimates the needs of Black patients. So the research I'm going to talk about today focuses on prediction models for suicide prevention. So suicide prediction models that use routinely collected clinical data have been developed and validated for several settings and are being used to guide suicide prevention efforts at multiple healthcare systems, including the Veterans Health Administration, Health Partners in Minnesota, and several regions of Kaiser Permanente. So one reason to look at racial and ethnic disparities in suicide prediction is that there is quite a lot of variability in suicide risk by race and ethnicity. What's unique about racial and ethnic differences in suicide risk is that underserved populations, including Black and Hispanic people, have particularly low rates of suicide death. White non-Hispanics, typically the group with the best health outcomes, have the second highest rates of suicide death, following American Indians and Alaska Natives. There are also variability in patterns of mental health diagnoses and treatment by race and ethnicity due to persistent disparities in accessing appropriate care, which we'll discuss more thoroughly later. And finally, suicide is a rare event, which limits the information available to identify race and ethnicity specific suicide risk factors. So for these reasons, it's important that we understand whether suicide prediction models accurately identify patients at higher risk of suicide in all racial and ethnic groups. For our analysis, we looked at a previously published model for predicting risk of suicide death in the 90 days following an outpatient mental health visit. So this model was published by researchers at the Kaiser Permanente Washington Health Research Institute and collaborators in the Mental Health Research Network. This suicide prediction model that we examined performed well overall. Nearly half of the suicide deaths in the data set had risk scores in the top 5%, and the area under the curve was 0.86. But we wanted to examine if that performance was similar across racial and ethnic groups. So this model was developed using data from 7 sites in the Mental Health Research Network, including Kaiser Permanente, Washington. And I'll describe a bit about the study sample. So the study sample included all outpatient mental health visits for patients age 11 years or older at the time of the visit. And these visits had to have 90-day capture of mortality data, including a description of cause of death following that visit. The outcome for the prediction model here is suicide death within 90 days of visit. And we have race and ethnicity data that were routinely collected by patient and self-report at clinical encounters. The race and ethnicity designations in the study do not reflect biological or genetic underpinnings, but rather represent how patients identify their race and ethnicity when asked about it in a healthcare setting. So throughout this talk, when I refer to race and ethnicity, I'm talking about race and ethnicity as a socio-political construct, not a biological one. So this table shows the number of visits and suicide deaths observed in our data set of about 14 million visits across 7 health systems from 2009 to 2017. So one thing that is obvious here first is that the majority of visits and of suicide deaths observed are among white non-Hispanic people. We also see a lot of variability in suicide death rates across racial and ethnic groups. So note that these are rates per visit, not per person, and a person may have multiple visits in the data set. We also see that the event rate for visits by Asian patients is higher than that of white people, which we didn't expect given population level trends. So this could be because the Asian people seeking mental health care in these health systems aren't representative of the Asian population nationwide, or because Asian patients at higher risk of suicide may have many visits, since this is a visit-based rate, not a per person event rate. We also see that there are a small absolute number of visits followed by suicide death for American Indian and Alaska Native patients, which will make prediction challenging. This is particularly concerning because we know rates of suicide death for American Indian and Alaska Natives nationwide are the highest of any racial and ethnic group. And at least to me, the most remarkable thing when I first saw this table is that the rate of suicide death is highest for patients for whom race and ethnicity is not recorded in the electronic health record. The suicide rate for this group is nearly twice as high as it is for visits by Asian patients, the group with the next highest rate. So we considered excluding this group from the analysis because unknown doesn't really meaningfully define a racial and ethnic group, but there were many visits from this group. The number of visits here is about 4% of all the visits in the sample. They have about 6% of all the patients in the sample and 10% of the suicide deaths observed in the sample. So it's really important that a suicide prediction model perform well with this group of patients. There are many reasons that patients might not have race or ethnicity indicated in the electronic health record. It might be that these patients are less likely to have encounters with the health system where this information is likely to be collected, or that clinic staff are less likely to ask them their race or ethnicity for whatever reason, or that they decline to identify with any of the categories offered. So predictions for suicide death in this model are made using data we have from electronic health records and health insurance claims data, including demographics, insurance type, and 5-year clinical history of diagnoses, medications, utilization, prior suicide attempts, and patient-reported depression symptoms from a questionnaire known as the PHQ-9. In total, we have about 150 predictors. So I'll pause for a moment for any questions about the data or the setup of the problem before I get to modeling results. I'm not sure if questions in the chat would show up on my screen right now. All right, if there aren't any questions, I don't see the chat, so someone please alert me.
Yeah, there are no questions in the chat.
Okay, great, thank you. Okay, so I showed data on the variability in outcome rates across racial and ethnic groups. But why else would we expect that a suicide prediction model may have performance differences by race and ethnicity? So first, one source of variability in performance across racial and ethnic groups could be differential assessment of predictors. It's possible that availability of clinical history might differ by racial and ethnic groups. This could be driven in differences by differences in enrollment history. So we don't have 5 years of history on all patients in our data set. So that might vary by race and ethnicity. And differences in insurance benefit structures could also affect healthcare utilization and the opportunity for diagnoses to be recorded in the medical record. There may also be differential diagnosing and treatment patterns present. We know that providers record different diagnoses and offer different treatments to patients of different races. And we know that patient preference about and the effectiveness of treatment varies by race and ethnicity. So the Mental Health Research Network has actually done a lot of research in this area. Some colleagues have led research looking at differences in healthcare utilization before suicide attempts and death. I have a colleague in the Mental Health Research Network, Karen Coleman, who's looked at differential diagnosis and treatment patterns across the health systems in this network. And one of her findings was that white non-Hispanic patients were more likely to get psychotherapy for depression and schizophrenia than Black non-Hispanic patients. There's also a paper from this group that found that non-Hispanic white patients are more likely to initiate psychotherapy or antidepressant medication after an initial depression diagnosis than Hispanic, Asian, and Black patients. So why do these differences matter for suicide risk prediction? These differences mean that the presence of particular medications or therapies in a patient's clinical record may not accurately reflect disease severity. And it's important to note that these differences in utilization and treatment are driven by structural racism and the longstanding barriers Black, Indigenous, and people of color face when trying to access appropriate evidence-based and culturally competent mental health care. So even racial differences in patient preferences for certain types of treatment are influenced by this legacy of receiving inadequate care. Another source of variability in performance across racial and ethnic groups is risk modification. That is, the relationship between predictors and outcomes may vary across racial and ethnic groups due to cultural differences influencing the strength of suicide risk factors, as well as protective factors. And we expect that this is the case for some predictors of suicide risk. For example, suicide attempts were more common for white patients who reported suicidal ideation than for Black patients. So reporting suicidal ideation tells us something different about a person's suicide risk depending on their race. Possible interactions between race and ethnicity and other predictors can be included in a different way in prediction models depending on the modeling approach being used. So a non-parametric machine learning approach like random forest can explore those interactions as part of the tree growing process. While for a parametric model like logistic regression, possible interactions need to be pre-specified. So we use 2 different methods to estimate prediction models for suicide death here. With our logistic regression with lasso approach, we included interactions between race and ethnicity and 10 predictors, including age, sex, some diagnoses, and prior suicide attempts. And we also used random forest. But the ability to identify interactions, either with random forest or with pre-specified interactions, is going to be limited because even though we have millions of records, the event that we're predicting is still very rare. As a result, the estimated model is going to be driven by the relationship between predictors and the outcome in white non-Hispanic patients, and predictive accuracy may suffer for other racial and ethnic groups. Finally, there's the potential for a differential assessment of the outcome, specifically whether a death is accurately labeled as being a suicide or not. For example, a study by Rocket and colleagues identified the potential for underestimating suicide rates in Black and Hispanic populations due to an excess number of deaths from injury of undetermined intent among people with psychiatric comorbidities. So I'm going to pause again for any clarifying questions before I talk about how we measured performance of prediction models. All right. So for comparing performance of the prediction models across racial and ethnic subgroups, there are many different approaches one can take to quantify prediction model performance. For this study, we selected measures that reflected how the suicide prediction model would actually be used in clinical practice. So the health systems that we're collaborating with plan to use this model to identify a subset of visits to mental health providers where patients are at the highest risk of suicide, and then initiate a suicide risk screening protocol for those high-risk visits. So when comparing performance of suicide prediction models across racial and ethnic groups, we're most concerned with how well visits are ordered with respect to risk, so that this group of highest risk patients is accurately identified. While calibration is a measure commonly looked at in evaluating prediction model performance, we weren't particularly concerned with the accuracy of absolute risk predictions because we were focusing on this classification and ordering. So that is not a measure that we looked at. So I'm going to talk about the performance measures we did look at. These performance measures are going to be familiar to many of those of you in the audience, but I'm going to take some time to explain them so that folks with less experience in prediction can understand the study results. So first, we looked at area under the receiver operating characteristic curve, also known as the AUC. Other terms for this are the C statistic, or referring to discrimination. And the AUC measures how well risk scores are ordered across the spectrum of risk. Can be interpreted as the probability that a randomly selected visit with an event has a higher risk score than a randomly selected visit without an event. And the AUC ranges from 50%, which is equivalent to random chance, to 100%, or perfect ordering of risk. So when we looked at the area under the curve across racial and ethnic groups for the logistic regression model, here is what we found. The AUC was really high among white, Hispanic, and Asian visits. The AUC was poor for visits from Black and American Indian Alaska Native patients and patients without race and ethnicity recorded. When we look at the AUC for the random forest prediction model, there's some movement in the estimates, but the overall story is the same. The model has high discrimination for white, Hispanic, and Asian patients, and low discrimination for Black and American Indian and Alaska Native patients and patients without race and ethnicity recorded. So next we look at the sensitivity of these prediction models. Sensitivity is also referred to as the true positive rate, abbreviated as TPR. So sensitivity is the proportion of visits with an event that have a risk prediction above a specified threshold. So this directly corresponds to how we're thinking about implementing a prediction model in real life practice. So if we select a threshold, we say all visits with risk in the top 5%, that's our risk threshold we're setting. Above that threshold, all of those visits are going to be offered a suicide prevention intervention. What percent of eventual suicide deaths would we intervene on there? So when we look at prediction model sensitivity, we see the same patterns, that the model best identifies high-risk visits for visits by white, Hispanic, and Asian patients, and not for visits by Black, American Indian, Alaska Native patients and patients without race and ethnicity recorded. So what does this mean? If we were to intervene on the top 5% of outpatient mental health visits predicted to have the highest risk using the logistic regression model here. We would intervene on nearly half of the visits with eventual suicide death for white non-Hispanic patients. Only about a quarter of the visits with suicide deaths for patients without race and ethnicity known, and only 7% of visits for Black and American Indian and Alaska Native patients, which is essentially as good as taking a random 5% sample of visits. So the model really does very little to tell us who is at risk here. And it's important to recall that the current situation in mental health is one where Black, Indigenous, and people of color do not receive as much mental health treatment. So if we have an intervention that will potentially reduce suicide risk, using this model to guide the intervention, we'll channel that intervention to white people and withhold it from Black and American Indian and Alaska Native patients. We also expect that patients without race and ethnicity known are also underserved because low utilization is associated with not recording this information. These patients will also miss out on potential benefits of the intervention. So one option for dealing with low true positive rates in certain groups is to set different thresholds for each group so that you intervene on the same proportion of eventual events. That is, you equalize the true positive rate across your different groups. So this is also referred to as equal opportunity in the algorithm fairness literature. So I'll illustrate that next, but first want to mention an additional measure of prediction model performance. We're also going to look at the false positive rate, which is equivalent to 1 minus the specificity. The false positive rate tells us the proportion of visits without an event that have a risk prediction above a specified threshold. So in practice, if we select a threshold, say visits with risk in the top 5%, above which to offer all visits a suicide prevention intervention, what percent of visits without an event will we be unnecessarily intervening on? So this is a receiver operating characteristic, or ROC curve, for the logistic regression prediction model. And I'm going to take a few minutes to walk those of you through it who aren't familiar with these curves. On the x-axis, we have the false positive rate, or 1 minus specificity. And on the y-axis, you have the true positive rate, or sensitivity. We have one line here for each racial and ethnic subgroup we looked at. Each point on the line represents one possible threshold for distinguishing positive or high-risk visits from negative or low-risk visits. And that threshold, each threshold has a corresponding true positive rate and false positive rate. So for example, if we set the threshold right here for Black patients with the blue line, then the true positive rate, or the sensitivity, is about 43%, and the false positive rate is 10%. So the area below and to the right of each curve is the AUC, or area under the curve. We have this line here at the x equals y axis for an AUC equal to 50% or 0.5, indicating the model is no better than chance. And groups that have a higher AUC here, visits from white, Hispanic, and Asian patients, have a higher true positive rate at each false positive rate along the curve here. So the curves go more to the upper left-hand corner. So as I mentioned, we could set different thresholds for each racial and ethnic group to ensure equal opportunity, or the same true positive rate or sensitivity across all groups. For example, we could want a true positive rate of 50% for every group. So we would select a risk threshold for each group and intervene for all visits with a risk score above that threshold in order to treat half of the eventual events or suicide deaths. Now, if we did that, we can compare the false positive rates across group. We see here that the false positive rate for a true positive rate of 50% is about 5% for visits from white and Hispanic patients, and about 10% for visits from Asian and Black patients, which means that in order to intervene on the same proportion of true events, we'd have to double the false positive rate, or proportion of visits without suicide death, incorrectly labeled as high risk for Black and Asian patients. So it's even worse for people without race and ethnicity recorded. The false positive rate is nearly 30%, and it's nearly half for visits by American Indian and Alaska Native patients. And for the sake of completion, here are the ROC curves for the random forest model. We see a higher AUC for visits by Asian patients here, the brown line. And the model actually does a little worse when sensitivity is fixed at 50% for white and Hispanic and Black patients than the logistic regression with lasso model. But we're still seeing this concerning disparity in the false positive rate if you were to intervene on half of the eventual events in each of our groups examined here. So I've shown how we could equalize the true positive rate across groups, but pointed out this big difference in false positive rate by race and ethnicity. Why does this matter? So first, all interventions have a cost. Otherwise, we would just give them to everybody. But the costs could include time, financial costs, care burdens, or side effects. And it's important when deciding how to implement a prediction model to weigh those costs or harms against an intervention's benefit. So spending a few minutes doing a suicide risk assessment at an outpatient mental health visit is relatively cheap and fast, and it might reduce risk. So we would generally think of the cost or harms as being pretty low. But an intervention's harms may not be the same across racial and ethnic groups. So suicide risk assessment, asking somebody about their suicidal thoughts and intentions and plans, can escalate to more intrusive interventions, including involuntary hospitalization and wellness checks conducted by law enforcement, which we know are going to pose much greater risk to Black, Indigenous, and people of color. So we may be very hesitant to implement an intervention that has a higher false positive rate for Black and American Indian and Alaska Native people, like this one does, if we know that the harms associated with the intervention are higher. So there are many other things to consider when inquiring about the equity of a prediction model. Equal performance of a prediction model on selected measures is just one component to ensuring that a clinical prediction model is equitable. It's also necessary to examine whether the intervention guided by a prediction model is equally beneficial to all groups. It's possible that patient perspectives on using patients' electronic health record data to predict suicide risk and to guide prevention interventions may vary by race and ethnicity. Also, our data do not reflect all of the people who need mental health care and suicide prevention treatment, nor all the settings where they seek care. The ability of any clinical prediction model to truly address health disparities is going to be limited by barriers to accessing care, including affordability of care and inadequate insurance coverage. We can also consider what other predictor data could improve prediction model performance in racial and ethnic groups where it's currently poor. And finally, I want to emphasize that the context matters. Prediction models are not being deployed in a setting where everyone's needs are already equally met, but rather in our current state with existing race and ethnicity-based inequities. So in this context, to implement a prediction model that provides less benefit to already underserved groups will exacerbate existing inequity and widen care gaps. Implementing a prediction model and the interventions they guide cost health systems resources. So we really have to question whether health systems' decisions to spend resources on prediction models that increase disparities rather than on interventions that will reduce inequities. So there are several statistical directions where we're taking this work next, including a grant we currently have under review at the NIMH. So the aims for this grant include defining prediction model target functions that'll optimize prediction model performance within subgroups of interest. This is essentially addressing the fact that target or objective functions and statistical models typically maximize performance over the entire sample and do not consider performance within subgroups. Poor performance within smaller groups, for example, visits by American Indian and Alaska Native patients, is going to have very little influence on the overall performance because that group represents such a small proportion of the entire sample. So we're looking at estimating subgroup specific prediction models using target functions that are designed to optimize prediction model performance within that group. We're also currently conducting chart reviews of possible suicide attempts to better quantify outcome misclassification so that we can then incorporate misclassification rates into our prediction model estimation and validation. And another major statistical limitation to optimizing prediction model performance within subgroups with lower prevalence is that the small absolute number of events observed. So we're going to design simulation-based approach to power calculations that'll inform the design of prediction studies with subgroup analyses. All right, that's the completion of my prepared remarks. I do want to take a moment to highlight the contributions of my collaborators, including Eric Johnson, Susan Shortreed, Maricela Cruz, and Greg Simon. And in particular, I want to highlight the contribution of Teresa Nguyen. Teresa is the Chief Program Officer and Vice President of Research and Innovation at Mental Health America. She sits on the Mental Health Research Network Stakeholder Advisory Board. And we consulted with her on our manuscript for this project, specifically to ensure that we discussed our research in a way that did not further stigmatize, did not further the stigma associated with mental illness or perpetuate racism. So I highly recommend collaborating with people who are experts in health disparities research and in talking about the intersection of health and racism as you engage in work like this. I also really recommend this blog post published in Health Affairs in July of 2020. The recommendations provided here provided a roadmap for us when we were writing about our research and planning this presentation. I can stop sharing now and address any questions there might be.
Thank you for the inspiring talk. Yes. So yeah, time for questions. Either unmute yourself or put them in the chat. Maybe I'll start then to give you time. So yeah, in terms of, say, bias and variance of our sort of estimates, of course, if we specialize the model for each subgroup, then we gain something in terms of bias probably, but we're reducing the sample size and losing something in terms of variance. I wonder if you were to consider other variables, like say self-reported gender, and that was to increase the number of groups, to what extent what kind of measures can you really use to be able to tell whether maybe the group is a bit too small, so the variance of your estimator there is too high, as opposed to compare that to what you're really gaining by lowering the bias of your estimator for each, by sort of stratifying by groups.
Sure, and I'd say that in particular, being able to include gender and particularly gender identity, not sex assigned at birth, would be a huge benefit to any suicide prediction model, because we know that trans and gender non-conforming people have higher suicide risk, but right now that's a major limitation in our clinical records data, that information hasn't been collected in a uniform way for very long. And the reason we're actually able to do this for race and ethnicity is that there was a requirement in the Affordable Care Act in 2008 as part of the High-Tech Act about meaningful use of electronic health records that said that health systems had to collect race and ethnicity data. So if we had tried to do this earlier, say 10 years earlier, we wouldn't have data on patients. So that example is particularly important. Yeah, so stratifying prediction models, like saying we're just going to use data only from Hispanic people to estimate a prediction model for Hispanic people would be ideal if we had enough data and enough events observed to do that. But suicide is luckily a very rare event and is going to require a lot of data to estimate those prediction models with precision. As a part of this research, we actually tried to see what would happen if we tried to estimate separate prediction models for all of the racial and ethnic groups. And once we got down to smaller groups, some groups that were didn't have enough events to even include in this presentation, the models just kept breaking because that was just not, there weren't enough events. So part of what we're looking at for this consideration of target functions to estimate group specific models is how can we share information across groups? So it's not a model that's ignoring race when estimating performance, but it's not just completely stratified, ignoring information. We're looking at how we can share information in a strategic way that might improve performance. And that's work to come, ideally, if the funding comes through.
Makes sense. Thanks. Maybe I was wondering, when you had the table with the AUC, area under the curve, and for different ethnic and racial subgroups, I wonder if you can deduce anything from the performances in terms of composition of the group where race or ethnicity was not recorded. Have you been able to speculate on that? Sort of given the performance of that group were low, more comparably similar to Black Americans and either minoritized community, whether we can deduce something or what the composition of that group is.
Sure. We haven't done any work with that group to try to do multiple imputation, because I think that this is information that is missing, not at random, that there's something associated with the lack of that information in the chart that is in addition to what information we've collected on people. We had a few hypotheses that we were trying to track down. In particular, and this is kind of a disturbing thing to talk about, I'll acknowledge. In particular, we thought that it could be many older white men from more rural areas who die by suicide by firearm, who frequently don't have many prior suicide attempts. And because prior suicide attempt is one of the strongest predictors of dying by suicide, for people who use firearms, they may not have prior attempts. We looked at that within the 7 different health systems that provided data, and we can't, we didn't find any evidence that that was likely the case. Just looking at the distribution of age, which is recorded for everybody. It could also be associated with kind of trends over time on when the need to collect race and ethnicity data was reimbursed differently and required differently with the federal regulations I mentioned earlier. But the real concern is that these are folks who are not getting healthcare more regularly, who could be at higher risk for outcomes that aren't going to be captured in clinical prediction models that use historical data because they don't have clinical care kind of routinely.
Thanks. So there's a question in the chat if you want to read it. Sure. To the public. So
the question in the chat is, since incidence of suicide varies by race ethnicity, did you consider other measures of performance, PPV and NPV? And I'll get to the second question next. So PPV is the positive predictive value. What's the probability that somebody who has a risk score above the selected threshold has the event? That kind of tells you, say you were to offer this intervention to everyone in the top 5%, or among that top 5%, what is the event rate? And so PPV does vary a lot across racial and ethnic groups because PPV is really driven by the baseline rate in that group or the prevalence. So to say we wanted to equalize the PPV instead of saying the sensitivity or the true positive rate, that's just not going to be feasible in groups where there are very different event rates. And that would lead to, say, actually having a worse PPV among, say, white people in order to make it equal to the PPV among a group that has a very low rate. But that's some pushback we got when we went to publish this paper. Among some folks, the idea of equalizing PPV is seen as this kind of ideal balance between sensitivity and specificity because it incorporates that false positive rate in there. So it's not feasible in this application. You're not going to be able to equalize PPV. That is in the paper though, and I can share those results later. I don't have them on slides. The negative predictive value is what's the probability someone doesn't have the event given that they weren't flagged as high risk. That's nearly 100% for every risk group for at any threshold we would have looked at because suicide is very rare. We calculated it, but I don't even think it made its way into the appendix because it's just like 99.9. So then there's a question of how we determined the tuning parameters for our model. So we did for logistic regression with Lasso, we just had that one tuning parameter that was the amount of shrinkage that we were able to tune. We for this study, we did a 50% training, 50% validation split because wanted to optimize the number of, or we wanted to kind of balance optimizing the number of observations for training and having enough events within groups to actually measure how well the model did. And we stratified that training or that splitting on both event status, if the person had any events, and race and ethnicity to do our best to balance that information between our training and validation sets. So we did, for the logistic regression with Lasso, tenfold cross-validation to get that shrinkage parameter lambda. And then for random forest, we trained our the number of variables to randomly sample at each split and the terminal node size. We'd done a lot of research on this data set and estimating these models on the data set before, so luckily we knew kind of the general neighborhood to look in. We trained the models to perform well on average. We did not use, there is an approach called worst case performance methods where we could have said, we're going to select the terminal node size that optimizes performance in the group that has the worst AUC, say at terminal node size. We did not use that for this method, but that's something that could also be looked at. And I think we selected tuning parameters to optimize AUC because we knew we were going to be worried about this ordering. Looking at loss, which is another kind of common measure of performance used for prediction models, looking at loss for really rare events can be misleading because the event is so rare. So that averaging over all of these rare events, really your loss is driven by your prevalence. So I tend not to use it when I'm working on the suicide prediction models as much. We've also done work in this data set seeing if we chose different, if we, if we used different measures to choose tuning parameters on the entire data set, did it matter? And I think later work we've done, at least with suicide attempts, found that it actually didn't matter. Just for this data set, not saying that it doesn't matter for anyone else. We just wanted to make sure our choices weren't sensitive to using AUC instead of the F-score or whatever.
Thanks. So any other questions?
I had a question, and thanks so much for this talk. It seems like one of the main issues you had in just fitting the model was the low number of events. And you talked about how you use suicide attempts as a predictor, but I'm curious if you thought about using that instead as the outcome, since you'd still be identifying high risk individuals, not just as a proxy, but even in itself. And that could result in greater event numbers.
Yeah, no, that's an excellent question. So yeah, prior suicide attempt is a predictor. And in our prediction models for suicide death, but our group has also worked on estimating models for suicide attempt. And those are the models that are currently being considered for use in the health system, predicting suicide attempt instead of suicide death. For this analysis, we chose to focus on suicide death because we knew the problem of a more rare event would be more important, but also because there are fewer opportunities for misclassification for suicide death. For suicide attempt, you have the same misclassification opportunity where someone makes a different decision about whether it was self-harm or not self-harm. But you also have the misclassification where someone does not go to the health system to seek care for their suicide attempt. So that aspect of the event, there's just additional layers of misclassification there, and they could be also associated with race and ethnicity. The work we're doing with chart reviews to understand, to better quantify misclassification, we are doing with suicide attempts, not with suicide death. So that is something that we will look at in the future.
Thank you.
Any other questions? Okay. Yeah, any final remarks, Yates, before we close it?
I really appreciate everyone attending today. I'm happy to answer any other questions about this over email.
Yeah, thank you very much for preparing this talk.
There are any, I think, yeah, that we have some opportunities for students to do work, kind of if you're interested in prediction modeling, machine learning, mental health. We don't have tons of opportunities. If all of the master's capstone students emailed me, I could not say yes to all of you. If a couple of you emailed, I could probably hook you up with some projects. So, and also just happy to talk to folks who are interested but don't want to work on a project.
So that Bruce unmuted himself. Bruce,
yeah, I just wanted to thank you, Yates. This is a very nice omen for the success of the subset of our seminar series. So, an important topic, of course, and solid work that has bigger implications. So, thank you, Yates. Very nice.
Okay, so let's thank Yates again. Thank you, Yates.
Thank you.
And I'll see you next week. Bye, everyone.